Welcome to the latest installment of the AST Journal Club series. Today's Journal Club features the article, Race-Free Estimated Glomerular Filtration Rate Equation in Kidney Transplant Recipients, a Development and Validation Study. This session is hosted by AST's Kidney Pancreas Community of Practice in conjunction with the AST Education Committee. In a moment, I will turn our session over to our moderators, Dr. Roslyn Mannon from the University of Nebraska Medical Center and Dr. Mona Doshi from the University of Michigan. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This Journal Club is being recorded, and the archive will be available on the MyAST website and the AST YouTube channel in 2 to 3 business days. Please note that all of your lines have been muted so that only the presenters and moderators can be heard for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via the normal chat may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline or post the full question with the answer to the website following the Journal Club. Finally, when you log off at the conclusion of today's session, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Mannon and Doshi, to begin our presentation.
Well, thanks, Brian, for your professional introduction, and appreciate being here. Welcome, everyone, to our Journal Club. Appreciation to the KPCOP and the Education Committee for allowing us this time to discuss this very important paper. We're going to go ahead and introduce our speakers. Our first presenter is Dr. Alex Loupy. Dr. Loupy is a professor of medicine and nephrology at Hospital Necker in Paris. Dr. Loupy is the director of the Paris Transplant Group, which is an epidemiology research group at the National Institutes of Health and Medical Research in France. He's also professor of nephrology, working in and has funded this research team since 2008. His work is focused and is quite broad. It includes artificial intelligence, multi-organ transplant analytics, as well as understanding outcomes in both xeno and allotransplantation. Mona, would you like to introduce Dr. Raynaud?
Yes, thanks, Roz. It is my pleasure to introduce Dr. Marc Raynaud. He obtained his master's degrees in mathematics and a PhD in epidemiology. He's a scientific leader of the Paris Transplant Group. His research is quite multifaceted and includes working with all organ recipients, kidney, heart, lung, and liver. His research focuses on allograft function, allograft failure, diagnosis, and prognosis based on artificial intelligence. I would like to now turn over to Dr. Loupy and Raynaud to start with the presentation. Thank you again for joining.
Thank you very much for the kind introduction. That's going to be a teamwork today between myself and Marc. I will start with introducing the global concept on why this is important that we have eGFR in different decision-making process and clinical trials. And then Marc will just present you everything you want to know about this BMJ paper, race-free eGFR equation in kidney transplant patient recipients. So why are we here? Because we need better models for prognostication, and eGFR is part of that. And a very interesting thing is you see that there is a funnel effect for all the models, which finally very few are making it into clinical practice. So one of the reasons is that most of the clinical trials are not really fit for purpose, and there are some hurdles for adoption, and it makes that the model cannot be really implemented into the clinical practice. So our research strategy and how we can advance the state of the art is by an integrative research strategy where we have built over the past 15 years prospective and selected cohort of kidney transplant recipients in which we have multiple evaluations, biomarker, environmental factors, and different gene expression in biopsies. But also we are doing a lot of eGFR measurements as part of the clinical practice post-transplant, which allows us to build this huge network of integrative research strategy, and then we can build patient contextualization system. So it's not only useful for GFR, it allowed us to move into more allograft allocation prognosis, gene expression, diagnosis, and therapy efficacy, moving to a more personalized medicine. So thank you for your attention, and I'm leaving the floor to Marc Raynaud, who will be presenting the eGFR equation study. So Marc, the floor is yours.
Thank you, Alex. So following what Alex just said about the importance of allograft function, I would like to present our recent international study in which we have developed a new race-free kidney transplant-specific equation. I have nothing to disclose, and these are the disclosures of Rose Mannon and of Mona Doshi. So these are the main GFR equations that you all know about. First, the MDRD was developed in 1999, which was followed by CKD-AP in 2009. This was supplemented by cystatin C in 2012. And more recently, this equation has been redeveloped, but without the coefficient for ethnicity. Importantly, these equations were at first developed and validated on native kidneys, and they were based on American data, which may limit their generalizability. And additionally, what we have observed is that these equations have suboptimal performances in transplanted kidneys. This is why in 2023, the KDIGO group has advocated for the need for a kidney recipient-specific equation, given the specific nature of these patients. They have published this in these guidelines for the management of the kidney allograft from decline to failure, published in Kidney International. We wanted to better stress that point by performing a literature review in which we have identified all GFR equations published since the beginning of medicine. We found 33 studies, among which 3 were focused on kidney recipients. However, they had many shortcomings, such as unicentric design or small number of patients, lack of external validation, and other methodological limitations. Following this, after the publication of the new CKD-AP 2021 equation, we published this letter to highlight some limitation in the validation process regarding this new equation and the need to investigate its performances in kidney recipients and how specific that population is. Based on this, we decided to develop and validate a kidney transplant-specific GFR equation and to compare the performances of this new equation to the current native kidney-based GFR equations, including the CKD-AP 2021. So this is the study design. We could gather more than 15,000 kidney recipients from 17 cohorts in Europe, the US, and Oceania. The patients were transplanted between 2000 and 2021. We could gather more than 50,000 GFR that were measured according to local practices, such as EDTA, DTPA, inline, or iotalamate. For each patient, we gathered donor, recipient, transplant characteristics, as well as information about the treatment. And this is the list of the centers and clinical trials included in this study. So centers from France, the US, with 3 clinical trials, and additional centers from Italy, Croatia, the Netherlands, Australia, and Denmark. What we observed in these transplant centers is that they were quite different in terms of allocation practices and medical systems, such as disease and living donor rate ratio. The dual kidney transplantation program were kind of different, as well as the pair donor exchange national program, as well as ABO and HLA incompatible program and the standard induction therapy protocols. Same thing from the cohort characteristics. We find heterogeneity regarding the recipient, donors, and transplant characteristics, but we were looking for this heterogeneity because it is very important when you develop a prediction model, or in this case, a new equation. When it is time to validate it, we need to ensure that it is working in different populations and subpopulations. Regarding descriptive statistics, this graph shows you the distribution of measured GFR in each center, and we did not observe specific outliers in the data. This graph shows you the relationship between measured GFR and creatinine for each center. So as you can see in centers such as Toulouse or Saint Louis, we observed a clear relationship, which was less strong in other centers such as the BENEFIT trial. Now, moving on the methodology, we have split the population in two, the development cohorts and a series of external validation cohorts. We used for the modeling linear regressions based on either additive or multiplicative models, and we have also used lasso regression. To assess the performances, we use the adjusted R squared, the root mean square error, and the mean absolute error to assess the model's fit. And to assess the prediction performances, we used the P30, which is the proportion of glomerular filtration rate estimation within 30% of the measured GFR. We used the P10, which follows the same principle. And we use the correct classification, which is the agreement between eGFR and mGFR according to GFR stages. And last, we used blend-Hartmann plots. Of course, we have followed all statistical assumptions for linear regressions, such as the fact that the predictors should be normal or should follow a uniform distribution, or the fact that the relationship between the linear predictors and the outcome should be linear. To report our methodology and our study, we follow the tripled statement. I think it's quite known now. It's used to follow prediction, to report prediction model from the background objectives to the methods, including outcome predictors, statistical analysis, to the reasons interpretation and discussion. After following all these steps, this is what we found. This final kidney recipient specific equation. On the top left, you have the model's fit. On the top right, you have the final model's coefficient. And importantly, the use of race, ethnicity data did not improve the model's fit nor performances. Therefore, this equation is race-free and contains the creatinine, the age, and the sex of the recipients with the squared effect on the creatinine. Now, moving on the performances. This graph shows you the relationship between eGFR, as estimated with our equation, and measured GFR. So in this case, for each center, we want a strong alignment between the blue line, which is the estimation of our prediction, and the black line. We found P30 ranging from 74% to 92%, which is overall very good. And we next tested the impact of the timing and number of GFR measurements. So for each center, you have on the column on the left, just the performances I just showed you. Next, we selected one GFR measurement randomly per patient. We selected one GFR measurement, but the closest to 1 year. And then we used the coefficients of the first equation, but using, applied to GFR measurements before 1 year or after 1 year. And in all these settings, we showed that the performances remained very stable. So the timing and number of GFR measurements in the modeling of the equation did not modify the coefficients of the equation. We next tested whether there was a center effect in the equation. So this table shows you the coefficients of the kidney recipient specific equation, including the center as a parameter with Necker Hospital as the reference. And we found that overall the estimates were not modified, nor the performances. Therefore, there was no impact of the center on the prediction performances. The next step was to compare our equation performances to other equations. So in green, we have our kidney recipient specific equation. In red, the MDRD. In gray, the CKD-AP 2009. And in blue, the CKD-AP 2021. We found that overall, our equation performed better. Same thing for the P10. I just showed you the P30. So this is the table showing you the P10 performances. And basically, it follows the same trends. Now, if we focus on the race-free GFR equations, we found that our equation almost systematically outperformed the race-free CKD-AP 2021 equation. Next step was to investigate the performances of our equation in stratified population, for instance, according to race, so in Arab, Asian, Hispanic, Indian, white, or Black patients, and according to sex, according to age, according to donor type, living versus deceased. And we found that overall, the prediction performances were stable and very good. The next step was to investigate the performances in additional subpopulations and clinical scenarios. So for instance, in overweight patients, obese patients, underweight patients, patients treated with CNI, mTOR, belatacept, with additional GFR measurement methods. And we showed that again, that the prediction performances were very good. Based on this, we developed this online application for clinical practice. So let's say we have a 56 years old patient with a creatine of 380. The patient is a male. This would provide an estimation of 18. And now let's say that the patient is younger. Let's switch the unit options. Let's assume that we're a different center. And the patient gender is female, and this will provide you with another estimation. So regarding the next step of this kidney recipient specific equation, we are now working with medical agencies. We are now starting to work also with transplant societies such as AST and EXOT. And we are now starting to work to engage and promote this equation with kidney societies such as KDIGO and also patients association. With that, I would like to thank all people involved in the study, the AST for the invitation, and you for your attention.
Thank you, Marc, for a very direct and quick presentation. So I would encourage all of you to read the paper itself and also to look at the 65-page supplemental files. I'll probably touch on some of the questions that you didn't have time to show. So I'm going to encourage everyone participating. We have about 50 participants to go to the Q&A. In the meantime, I have a very simple question. I am not someone that does analytical development, tool development, and I wondered if you could just briefly touch on the P30 as a tool that is considered appropriate to determine the extent of the predictability of a marker, and what is the threshold metric? Is it 75%? Is it 90%? I mean, you said it was good, but I didn't delve into it in my reading in the background. If you could elaborate.
So thank you, Rose. It's a very good question. It is a key question, actually. So the gold standard to assess the GFR equations performances is the P30. But and to address your question, the threshold value is around 85%, but there is no real consensus about it. So we assume that above 80 or 90, it means that the equation performs very well. But this metric is not enough. That's why we assessed the P10, the blend Altman plot, the correct classification, and additional metrics regarding the model's fit to ensure that the equation performs overall well according to several statistical criterions.
Great. We're starting to get, I know Mona has a question and I have more, but let me go to the first, a question from an anonymous attendee. Did your analysis look at the impact of size mismatch transplants and the impact on estimated GFR result?
No, that's a really good question. We did not assess that in our study.
Perfect. And then I have a question. First of all, I want to congratulate both of you on doing such a remarkable study, such a large population, very statistically sound study. So the question that comes to my mind is, are all Black patients similar? There have been other studies, done in Afro-Brazilian population, sub-Saharan population, where actually race-free CKD-EPI perform much better than including the race. So it does look like there is something beyond GFR that determines creatinine levels, right? And you acknowledge that in your discussion too. And the proportion of Black individuals in your, development and validation cohort was maybe around under 10%. So do you have plans to expand this to, maybe African or Brazilian Africans and other cohorts where actually CKD prevalence is quite high in the world?
So it's a very good question, Mona, and we are starting to work to collaborate and include data from additional centers worldwide. However, as you may know, it's quite challenging to include diverse populations such as Black patients, for instance, in Asia or Europe. Of course, the proportion is reduced. We try to collaborate with African centers, but obviously the kidney transplant activity is a bit reduced there, so it's quite complicated. And we also attempted to contact the centers from the US with the highest proportions of Black individuals, but they were not measuring GFR. So quite complicated, but the work is in progress. And we are also now starting to work with South American centers.
Yeah, if I can add on what Marc just said, we were super inclusive in our design and we reached out to hundreds of centers. The bottleneck really was, especially in the US, that not many centers are doing measured GFR. Yeah. And probably they are right, because it's not, we'll say, super clinically helpful, except to do papers and to generate those race-free equations or these equations. So we pushed it. We were also pushed by the referees and during the reviewing process to address also the performance in African European. It's what we did in the study, obviously. Brazil, I mean, we are just coming back from Brazil with Rose. They have amazing programs there with a lot of patients. And that will be great to validate that in South America. Unfortunately, the centers which we contacted do not perform measured GFR in those centers. Yeah. So anyone wants to collaborate from the participants, the audience, we are really willing to do so. And so don't hesitate to reach out to us, because that's a very important question for the widest generalizability of the equations.
Yes, and I think you can see that in the figure where you showed the performance of all the equations by country. It performed very well in certain countries, and in Croatia it didn't. And, maybe I don't know whether it's body surface area, muscle mass, et cetera, as I said, non-GFR determinants. So that would be great. Thank you.
And what was going on with Croatia? It does sort of stick out, but I'm trying to, I've never been there. So I'm Googling and doing images and trying to understand more of the metrics of their transplant programs. As Mona points out, are they more Europeans? Are they all skinny, older people? Or, because it's skewed versus the other European populations. I mean, you must have thought about it, and it doesn't distract from the paper. It's just sort of sticks out as sort of an interest point. any thoughts about? I mean, I don't want to belabor that because it's probably not your key point, but the naysayers will look at that and say, oh, it didn't work there, but we're not like Croatia here, so I'm not too worried.
So you know, Rose, we asked the exact same question to our collaborators from Croatia, and we discussed a lot about this with them. And we do not think that the Croatians are outliers in Europe, but unfortunately, we do not have a clear answer. It may be related to the GFR measurement methods. It's quite difficult to answer that right now.
Yeah, but as you pointed, Rose, also the referees, pushed us pretty hard in that, and they were right. And especially in Croatia, the data are the data, right? They send us the data and they say, with Marc, they say, oh, there is a problem. There is not a single Black people there in their cohort, like it was zero. Yes. I say, there must be a mistake. I mean, you must have, but they say, no, we don't. So, I mean, we have to also tackle and understand the programs, the populations. Obviously, Croatia has some differences in the population actually that they transplant. But that's really something that you are right to point out.
And I think as we talk about the generalizability, if I looked at your demographics, right, BMI of 25, 9% Black, and, going down to like percentage diabetics of 20%. So it may vary, right? If those factors play a role in determining, GFR, definitely the BMI, the height and the weight probably plays a role in these variances. And perhaps I'm like, are we trying to put too many people in one box, right, with one GFR equation, and it may not be.
So Mona, here comes the point where, we were also discussing with native kidney people. They want one single universal equation, right? And Rose is aware of that because as part of the CADIGO initiative, right, we had some comments from, Dr. Levy and Dr. Koresh and Morgan Grams. It's already really hard to make them understand that the transplant population is different from the native kidney. I think also the multiplicity of equations will lead to the fact that they will not be, endorsed or adopted. So what I think will be a right path towards in transplantation to add more different heterogeneous population and see if we can perform well and maybe adjust some coefficients. But it also brings the point to a universal single equation, and I don't think it's the path forward. Despite the fact that the native kidney people working on GFR do not like that we are pushing a transplant-specific race-free eGFR equation. I can tell you they don't like it, but we can make the point, we can discuss with them and say, look, we are nephrologists, but also transplant nephrologists, and I can tell you it's different from native kidney, right? And we've seen that because the performances of the race-free CKD-AP equation was not good, and we performed way better with that one, which was designed in a transplant population.
And that's an important point. I think you did show the data very nicely, Marc. No offense, I've read this paper a couple of times, so not as a reviewer, in full disclosure, but also that this equation did do better than the most recent CKD-AP. And again, we know these are approximations. So I have a couple of questions that are sort of burning. One is going back to generalizability. Dr. Blanche Chavers asks whether pediatric patients were included, and if so, did you have any modifiers in those groups?
So we did not yet investigate the performances in this population, but it remains to be done.
Another thing we just touched on it. I know Mona's going to ask this in a minute, but she touched on it. Is can we talk a little bit about the non-GFR related determinants of creatinine in the transplant patient? Because I don't think people really think about them, and I think our and also talk about some of the much smaller studies in transplant development of equations. So let's just tell us a little bit about what you think are some of the key non-GFR related determinants that you have to pound into the heads of the nephrologists that are holding on to the CKD 2021 epi equation.
Oh, that's the
Just a couple. I mean, you know,
Yes.
corticosteroids. There's
But
one. That's an easy one.
I'm sure you have
BMI.
some thoughts about it. I'm sure you have some thoughts about it. No, I mean, it's a tough question, you know, determinants of GFR. And we know that there are some factors that can affect, you know, serum creatinine post-transplant, like the use of what we give back cream. I don't know the name. And there are conditions post-transplant, you know, inflation of volume and other agents. We talk about ethnicity, we talk about BMI, we talk about different conditions. So really, I think the study cannot address this question, to be honest. It was just like a measurement of GFR and estimated at the same time building the equations. So I'm afraid I don't have more insight, but I'm sure you have.
Well, you do have supplemental data that you did not show, a lot of additional not adjustments, but looking at specific factor performance that we should probably remind people to take a look at. You show that in detail in the supplement, but I'm going to turn a little bit over to Mona because I feel like I'm dominating the conversation, and we still have a bit of time, and I have a lot of questions. So.
Perfect. Thank you, Roz. And no, you know, this is very interesting. So I'm just going to circle back with generalizability to other populations, right? Because if we really want a transplant-specific equation, then it should have, and a unifying equation, it should be applied to different populations, perhaps in context of research and maybe some grant funding that will allow centers, right, in other countries to perhaps run this as a research arm and not a standard of care to get measured GFR. So I think this is just a suggestion if we really want to move this field forward. But then next, where do you say in an ideal world, say we got this data from every single country, right? And this is the best equation. Where do you foresee it? Like, do you use it today in your clinics? In the clinical use, how do you see it?
Take that, Marc? I can complete after.
Okay. So we are trying to define a pipeline to make sure that this equation is used worldwide in kidney transplant practice. So first, we would like to engage and promote this equation with kidney societies, transplant societies, and patient association. And we have developed this online application. It is free. It is already accessible. It is very easy to use. So these are the first steps to be sure that it is used and help the clinical decision making.
Yes, Marc is right. And if I give you a little bit of insight, so we have engaged discussion with the French Society of Transplant and the ESOT, European Society of Transplant, just to try to fertilize the use of the equation. As Marc mentioned, it's completely open source, open access, and I think the publication is quite strong. We also have engaged discussion with routine labs. For example, routine labs in our hospital, they are using, CKD, AP, whatever equation. So why not, if you are transplanted, race-free eGFR equations that we have built. So this is really important for us because I have this conversation with Marc. Say, Marc, it's a huge effort. I think it's a great paper, but now how do we bring that into clinical use? How do we bring that and leverage the fact that the labs now report for the transplant population, the race-free eGFR? And it's, to my point, also important in Europe. Look, in France, you're not able to use race anywhere. So per se, it has some good points, but also any patient in France that has an eGFR is considered to be Caucasian. And I think that's not fair, to be honest. Yeah. So this is where in my country, the race-free solves all of that and provides a better and more accurate, and we have to change it. And in some countries in Europe, per se, you are considered Caucasian. So we have African European, which are in France, put into the Caucasian population corrective factor for the eGFR equations. And we think it's not, from a medical standpoint, it's not good, but also, we cannot accept that. So we are working with routine labs, and we are also, trying to, that's what we do today. And that's the reason why we reach out to Rose also. And we are grateful that we can present the study at AST. to leverage the endorsement of the equation to be used. It's easy open access, as you said, and the benefit over the native kidney-based race-free equations is clear as well.
No, absolutely. And I think apart from society getting to the labs to help, to make sure they add it and they report it to the, the lab report, because it is very important even to study them serially, right? So every time you go in, you want to make sure it's easily accessible and you can study the trends, because these are not extremely accurate. You want to just look at the trends to make good judgments. So a great question, but maybe until all the labs adopt it, perhaps this might be the new tool for research, when you looking at research endpoints across different, for maybe a new rejection medicine or something where you are recruiting from centers all around the world. Maybe this is where we could see implementation. Okay, so I'm going to go back to a question that we have here. Is that, did you exclude transplant recipients within the first few months after the transplant, as the allograft function may not have reached a stable level?
Yeah, answer is yes, we did. Part of the eGFR measurement protocol, mostly in France, which is a big component of the cohort, were done in patients at a steady state post-transplant in the first year, mostly as 3 months and 1 year post-transplant. We avoided situations in which you are completely destabilized, especially the early phase post-transplant.
Perfect. Thank you so much.
Someone has actually been participating and listening and connecting the two talks together. So Jessica Voss is asking about, have you started to use this equation in the iBox calculation?
Yeah, so that's a really good question. So the answer is yes. So now we are using the eGFR, the race-free eGFR equation in the iBox algorithms. The thing is that we need also to engage discussion with FDA and EMA, because if it's going to be a new standard of care, I mean, that doesn't destabilize iBox, right? If you use the race-free or the standard in iBox, for prognostication, it doesn't change, much the predictability.
The coefficients that we have developed with the iBox can remain unchanged.
Exactly.
Okay.
The coefficient.
That's a good point, because it's sitting in the FDA inbox as the qualification plan to include iBox as a new reasonably likely surrogate.
Yeah.
So a follow-up question was, how would you incorporate this into clinical practice as most US centers? I mean, when I was training, which is back in the dark ages, we used to do this annually. We would put people through either IFL-MAID or try to get a 24-hour, but now it's not done, and the inconvenience and the cost isn't supported by either the patient or company or insurance. So do you foresee this as an important aspect? Do you think we need to be measuring more eGFR, I think is the question. That's my one interpretation of that question versus, is this, to me, a clinical implementation tool or a trial endpoint tool?
Yeah, it's both. But no, coming back to the question, I think doing measured GFR has very little clinical value, to be honest. We have been done that for the past 20 years in my center for every single patient. And, in France, we have to spend money on healthcare, right? So it was helpful to generate those estimator equations. But to be honest, the clinical relevance of doing measured GFR, we have tried to do a lot of analysis about measured GFR versus estimated. The gain that you have, even in the iBox equation, is very low. The gain that you have in decision-making process, to my point, is very low. So it's a good tool for research. It's a good tool to actually generate those equations. That was super helpful. And the biggest center in the US actually doing measured GFR is Mayo Clinic.
Mayo, yeah.
Yep, Mayo. Yes.
So it's great contributor in the data set. But I don't see any clinical benefit to do it. I think in my center, we just now gonna stop doing measured GFR.
So I have a question. If your center was doing measured GFR, did you guys do cystatin C too? Do you have any data with cystatin C?
Marc, you want to take this one? Because I know that it's a super sensitive topic for Marc because he's been challenged is always challenged with cystatin C, but maybe Marc, you can answer that.
Yes. So we could gather very few data on cystatin C, not enough to be able to test the performances with or without the cystatin C data on the equation. And so as far as I know, it's very unlikely in Europe that it gets reimbursed. So the creatinine-based equation, I think it's the solution for the transplant
yes.
practice activity.
Yes, so cystatin C has been around. I think cystatin C is good. Huh? I think it's great, cystatin C. The performance you can get with cystatin C are really good. But the thing is clinical implementation, right? So in Europe, in France, some people tried. They say no way because the price was too high. And so we abandoned cystatin C. That's why we do not have a lot of data around cystatin C. So for research, some people are doing it. I think it's interesting. But if we think about like wide implementation, and the price is like 7 times the price of what you get for like a routine serum creatinine, I'm not in favor. But I know, again, native kidney people, they want to impose cystatin C now, and they are pushing it hard. And they have the argument to say, oh, it might be less expensive with years. Let's see. But for the moment, worldwide, cystatin C is not widely used, to be honest.
Yes,
so
and it is not.
Question.
It's not even available everywhere, so that might be a problem, at least in many countries, right?
Of course.
So that's a good one. Okay.
I see another question, interesting question, Ann Halpin. You know, do you see any merit of this for living donors post-nephrectomy in terms of accuracy of assessment? Yes. Or I mean, you may not have looked at that, or is this really, we send them back to CKD-EPI 2021 and say, oh, you're a nephrectomy patient. So any comments about that?
Yeah, that's a good question. We have not looked specifically into it. We know that, so the way we evaluate living donors are standard, but they get measured GFR for sure before donation. And after donation, we follow them, but we don't do measured GFR post-transplant to our living donors. We do sequential, serum-based, like creatinine evaluation, protein, blood pressure. So I don't know which one would apply if you get a nephrectomy. I think one of the criteria that makes transplant recipients so special is the fact that they have a wide array of different treatments and maybe allograft injuries and natural history and CNI toxicity, hemodynamic effects. So all of that, I think, are encouraging for doing the race-free GFR using transplant-specific equation. But for native, kidney donors, I don't really know.
So now that brings me to the next question. What about people who've had non-renal solid organ transplants like heart or lung, or pancreas, where they're exposed to all these drugs, but they have 2 kidneys?
That's nice. Yeah, I have not thought about this one, to be honest, but that's super interesting.
That's Marc's next project.
That would be the next study.
Super interesting.
Thank you, Mana.
No, that's super interesting. Yeah, I've not even thought about it, but yes, you're right.
Because they're on spectrum, they're on the same drugs, right?
Of course.
Yeah.
Of course.
So Mona, you're thinking the heart, non-heart liver, non-heart kidney, just the kidney.
Just any other non-renal solid organ transplant recipient that are on the same very drugs with the same, Bactrim and prednisone and all those other things that we think may affect the muscle mass, may interfere with secretion of creatinine, CNI toxicity. But the only thing is they don't have ongoing rejection, but they do have CNI. And, most of, I think a lot of non-renal transplant recipients, right? Solid organ transplant recipients end up needing a kidney transplant down the road. So, monitoring and having an accurate estimation of their kidney function is so important.
Yeah, Mona, you're right. And with hearing your questions, I start to think about maybe new ideas. So Marc, what we have not done, but we can collaborate with the team of Dr. Levy is we should validate maybe our transplant-specific equations in native kidney and see how it performs. Back and forth, we do the opposite and we see if we can transport The reason why I say that is I mean, what we have experienced with the discussion with native kidney eGFR people is the same that the discussion we have with them. They say, okay, for example, we have a native kidney equation that predicts when you will be on dialysis. What's the name of this equation? The KFRE equation, derived in native kidney based on registries. Your native kidney, whatever your nephropathy is, it predicts the time will you be on dialysis. So this score is not really good, not well calibrated, not well validated. But some people say, oh, why do we need iBox? We have this kidney, native kidney score. We can just apply post-transplant and it's be as good as iBox, which was primarily designed in these transplant populations. So it's absolutely not. You are not expecting a native kidney prognostic equation to perform super well in a transplant population, especially in subpopulation with AMR, TCMR, where you have injury, scarring, damage, HLA antibodies. But some people really think, and it's not because I'm a kidney transplant physician that I'm advocating for transplant specificity necessarily, right? But for that, I think it's also something of that is important.
I like your idea of swapping because maybe there are all those GN patients who are getting all these medicines, and maybe it might be in some subpopulation it may do better. But anyways, I'm going to pass on the baton to Roz if she has any other burning questions.
Oh, I always can find another question. So I'd like to circle back to the notion of CNI-based immunosuppression versus non. So you were lucky because you had some cohorts where there was zero use of CNI, whether it was the Bella cohort or intentional use of mTOR. You know, the classic argument of CNI is vasoconstriction, both acute and chronic CNI toxicity. Of course, I study it, so I'm always kind of hot on it, but also looking at the long term and the differences between TAC and cyclo. So again, tell us a little bit about your observations of the equation, how it wasn't affected. This is so important because the clinging to this notion that the CNI, I mean, we see it in clinic. I get it. We stop the TAC or the TAC level's high and it's an indicator, and the creatinine goes up and we use that as an indication. But in terms of measuring or estimates of GFR, can we talk a little bit about it? It's important too for regulatory agencies to understand that we have to stop clinging to this theory of 20 to 30 years ago, or even 5 years ago still.
So thank you for your question. We have looked at the performances and we stratified them according to many different treatment and subpopulations according to the induction therapies. And we found that overall the trends remain the same. However, we have some centers, some treatments are specific to some centers. So it's difficult to assess whether it is dependent on the treatment or dependent on the centers and therefore the population. But overall, the trends regarding the performances remain the same according to the treatment.
And, you know, we have included the benefit EXT trials where they have mGFR, measured GFR, and we found the consistency of the performance, especially Rose in patients with belatacept, because you were mentioning this hemodynamic effect. And it just echoes also, and you're right, I mean, this hemodynamic effect can be like sometimes pain in the ass, right? We always ask, oh, it's hemodynamic effect. So we are also tackling that, as you know, Rose, with the iBox, because iBox was primarily derived in mostly a CNI-based regimens. We found that actually the performances are as good as in CNI as in belatacept. In our population in which we switch to belatacept, we found good performance of iBox. That's the same for race-free eGFR equations. Not to say that the hemodynamic effect does not exist. It does exist, but it does not affect so much neither the formula nor the iBox performances. So it's a very important point to mention.
I think, go ahead, Mona.
Go ahead, sorry. What about the steroid use? You know, one of the main arguments to do this was, you know, steroid use, muscle wasting, etc. I couldn't find any details on whether the steroids, you know, how many recipients were on steroid-free regimen and what was the dose, etc.
Yeah, so I would say in the development cohort, and I'm going to talk about the development cohort in Paris, they are mostly, most of our patients are on triple immunosuppressive regimens, including steroid. The scheme that we use in steroid after induction is we maintain a dose of 10 milligrams per day until year 1, and then we reduce at 7.5 milligrams, and we tend not to stop them. I don't know if we are right or wrong, but that's the way we do. So most of the patients in the derivation cohort were under steroid therapy.
That's okay.
Yeah, and in the other centers, we did not have all the information about treatment, I think. So it's just like real life setting. So there might be some patients in non-steroid based therapies as well.
Perfect, thank you.
I know we're almost running out of time. I just wanted to touch on one last methodologic issue because I wasn't sure I understood it, but tell us just briefly a little bit about the variable selection that you did. And I know one mention was, and we also consulted experts in this area to get their input. Marc, any thoughts about or comments that you could provide us to understand how that happened? Did it take a lot of time? Could you get pretty good consensus?
So usually when you develop linear regressions, you perform a stepwise backward elimination to select the final parameters. But this now is has been considered as biased, So to us, the ideal strategy is to use this plus all our expertise from either the medical practices or the transplant literature. So the idea is to combine everything to test as many combinations as possible and to select the one with the best performances. That is for the linear regression part. And we have also tested lasso regressions, which sometimes help to select, to better select parameters. But as we showed in the review process in the BMJ, this did not improve the performances. So we had these 3-4 steps to select the variables.
Well, great. Thanks for that explanation. We have just another minute. Is there anything else, Mona, that you wanted to ask? I asked our audience if this is their last chance, because sometimes it's intimidating at a national meeting to come up to the microphone. So this is a little bit easier to do, but.
Yes. I just want to end, at least my last comment is, thank you so much for moving this field forward. And I hope to see down the road participation from other countries where the prevalence of CKD is quite high, and, include them and see where this goes and perhaps integrate into regular practice. So that's my closing remarks. Roz, do you have any?
No, I want to thank both Marc and Alex for at least the time change worked well for them and fitting it into their schedule, and for the participants that have been listening in. There's also a recording that's available to any registrant as well. And otherwise, with that, I think, Brian, I'm going to turn it over to you.
Thank you so much. AST would like to thank Drs. Raynaud, Loupy, Mannon, and Doshi, and the leaders of the KPCOP, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/Journal Club to view our video archives and register for upcoming AST Journal Clubs. To learn more about AST's Kidney Pancreas Community of Practice, please visit myast.org/COPS or connect directly to the KPCOP Hub online. Thank you all for today's session.